Boa noite a todos, bem-vindos a mais um Clube da Artéria. É um grande prazer estarmos todos reunidos aqui mais uma vez. Hoje temos um Clube da Artéria especial, contamos com a presença do professor Milner. Milner é conhecido de todos nós, ele é professor da seção de cirurgia vascular da Universidade de Chicago, um grande entusiasta do tema da dissecção aórtica. E antes de passar a palavra para o professor Ross, tem alguns recados. O primeiro recado é que os participantes que tiverem interesse em receber nossos avisos de novos eventos, podem enviar um e-mail para pós-graduação@centervasc.com.br, que nós incluiremos na lista de avisos sobre eventos, cursos. E no evento de hoje, nós contaremos com o recurso da tradução simultânea. Todos vocês podem notar que existe um botão na base aí da tela escrito interpretação. Quando vocês clicarem nesse botão, vocês podem optar pelo áudio, ou o áudio original, ou o áudio em português. Nós contamos aí com o Ristow, nosso tradutor, que vai realizar a tradução aí durante todo o evento. Então, sem demorar mais tempo, hi Ross, nice to have you here at Clube da Artéria. We call it Clube da Artéria, Artery Club. It's very nice to see you again, and it's up to you now.
Great. Thank you, Bernardo. And thank you very much for the kind introduction. As you know, intendo un poco. So I understand a little bit of the intro, and I really appreciate all your kind words. And it's an honor to be back and join you for this evening. I wanted to share some thoughts about aortic dissection today, and not just some of the clinical work that many of us are familiar with, but share with you some of the work that we're doing to better understand aortic dissection from a research perspective, and hopefully explain to you in a way that makes sense that we're starting to believe at our institution that there's more to aortic dissection decision-making than just the timing alone. And I know a lot of what I will talk about is based on whether or not this is a patient that you're seeing that has an acute or subacute or chronic dissection. But I think we're starting to understand a little bit more, maybe physiologically, in terms of understanding who is going to have a good outcome from TVAR. And I'll explain that as I go through the presentation. So I do have a number of disclosures. Many of you are aware of this. I do a lot of work with industry, SIDAR, Syndrix, Enduron, Endospan, Mavericks, Medtronic, Shape Memory, Silk Road, and WL Gore. I will show some devices today. The point of this talk and discussion is not to promote a specific technology at all. It's more to talk about the disease state and some of the research that we're doing. As Bernardo said and gave me in that kind introduction, I am from Chicago. I know many of you know the geography well. We just sit right on Lake Michigan. In fact, when I look out the window close to where I'm presenting here, I see a beautiful view of the lake tonight with the sunset. And it's been a great place to work. This is the university itself. When the weather's nice, it looks like this. It's nice and green. It's starting to get cold here, as you know, so it's not so nice and green anymore, but you can see a great view of the city and the lake. And then here's the hospital where we do the majority of our work. There is more than one hospital building, but this is our newest building. It's a little over a decade old now, and it's where our operating room suites are and where I am sitting right now, actually in that building. So focusing on aortic dissection, as I know everybody is aware of the different classification schemes, the Stanford scheme and the DeBakey scheme. I'm not going to talk that much about the SBS recommendations, the combined SBS, STS recommendations. I don't think that's been used as much as people thought it was going to be used. But I think people still typically talk more in the way of the Stanford classification. So when you look at this, a type A means it involves the ascending aorta. As you know, you differentiate a DeBakey 1 or DeBakey 2 based on the involvement of the remainder of the aorta. A Stanford type B involves distal to the left subclavian artery, and the extent will then characterize whether it's a DeBakey 3A or 3B. But one of the things that we've all learned is we've gotten better with the medical management of type B dissection. We've understood that TEVAR clearly plays some role. We don't always understand of which patients we need to treat and at what time point, and that's hopefully what I'm going to be able to explain a little bit more today with my presentation. As we all know, type A dissections require emergent surgical repair. If it's a DeBakey 2, those patients still need to be followed because they're at risk for other dissection disease in their lifetime, but typically are quote unquote cured. DeBakey type 1 is one of the most challenging patient populations I think we take care of, in that they'll have an ascending repair or potentially a hemiarch, or in the hands of a more aggressive cardiac surgeon, an entire arch replacement, but they still have a lot of residual dissection that typically needs to be treated. In fact, the first case I did this morning was a gentleman who had a type A dissection, has residual dissection. A lot of those patients we do with a total arch reconstruction, but he was not a candidate due to not being able to tolerate the circulatory support. And about a month ago, I had done a 4-vessel cervical debranch, and today did a TBE based on the left subclavian artery to perfusing the entire brain. So the patients with the residual dissection after a type A repair can be fairly difficult. So as I mentioned, I'm going to talk about geometry and the timing of TEVAR. And every time we think about TEVAR with aortic dissection, I think all of us know that the reason we just don't treat everybody with TEVAR are the potential complications associated with the procedure. We know medical management is reasonable in a subset of patients, and potentially those patients won't need an intervention, but many patients do. And one of the things that we find very challenging are those patients that go on to have a chronic dissection, that even when we treat with TEVAR or with a petticoat or other type of techniques, we still have the false lumen filling that can be very challenging to treat with the chronic dissections. The complications associated with TEVAR, as everyone is aware, is the risk of access or vascular injuries, although typically these patients usually have reasonable sized vessels for us to navigate even with large bore devices. The risk of a TIA or stroke. Any procedure we do has a risk of infection. Clearly persistent false lumen flow. I put etc. here, but I'm specifically going to talk about retrograde type A dissection in a few minutes, and all the things we worry about when we're making a decision for whether or not a patient is an appropriate candidate for TEVAR compared to medical management alone. Share with you a case. I think I've shared this case with some of you previously. This is an 82-year-old woman who was transferred with an acute dissection, admitted for blood pressure control. She has a CTA on admission and again prior to discharge. And in our typical medical management, what we do for these patients is bring them in, get them controlled, image them again before they leave. So you see her initial CT, not that impressive, a typical type B dissection. She does not have any complications, meaning there's no evidence of malperfusion, either radiologic malperfusion or clinical malperfusion. She has no evidence of dissection. So by definition, we would say this is an uncomplicated dissection, at least on presentation. I'll show you that it was not. Here's just reconstructed images of her initial CTA. She was discharged, follows up in clinic a little bit later than a month, but followed up in clinic, and then I'll share with you the repeat imaging. So here you see in just a relatively short period of time, a dramatic change in the way her aortic dissection looks. There's been total aortic diameter increase, significant increase of the false lumen. There still thankfully is no malperfusion or rupture, but she now is clearly a complicated dissection. And here's the reconstructed image of what that looks like. So when you compare these two, this is in less than a 2-month period of time. She's had significant growth. And part of the reason I always like to share this case example, I don't think for a lot of us, we would think that in an 82-year-old, our typical decision-making is to proceed with TEVAR. But here, in less than 2 months, this woman is degenerated dramatically. So I think when you look at a high-risk patient who's going to benefit when you try to weigh the risk and benefits of TEVAR, this patient is clearly someone who is not doing well with medical management alone and is going to benefit from TEVAR. Some of her high-risk characteristics, and I know these are controversial, but her false lumen at initial presentation in the proximal part of her descending thoracic aorta was about 23 millimeters. The data, although it's a small number of patients where this data come from, says if you're greater than 22, that's a high-risk patient. On initial presentation, her total aortic diameter was about 45 millimeters, which again, a little bit of debate in the literature, whether it's 4 centimeters or 4.5 centimeters, but clearly at this size, we start to know that this is potentially a patient who is high risk. Even knowing this at the time, in an 82-year-old patient, I probably still would have recommended medical management alone. But this is the issue. Less than 2 months later, she's expanded from 45 to 72, and this is dramatic. So what's going on with this patient? Large false lumen at presentation, total aortic diameter greater than 4, rapid false lumen expansion with a large diameter of her false lumen initial presentation. I treated her with a TVAR with 2 devices in the subacute phase. I did not place a lumbar drain and was able to discharge the patient 2 days later. See her back at 6 months. And here you can see really, really tremendous remodeling. And so some of the question is, how does a patient like this remodel so dramatically? And one of the nice things is, if you look here, you can see I treated this patient back in 2016, and I've seen her annually since then, and she now has 7-year follow-up, and you can see there's still complete remodeling, no false lumen essentially present in the chest, an intact device, and a stable diameter of her abdominal aorta. So what's my algorithm for this? We've talked about this before when I was in Brazil, but for complicated type B aortic dissections in the acute phase, we treat those urgently. We cover as much length as needed. For a rupture, we cover the entirety down to the celiac. For malperfusion, we usually start with one piece, and if it's not sufficient, extend down to the celiac. And if that still is insufficient, we'll put a bare metal stent. Obviously, when you treat these in the acute phase, you need to assess for the risk of retrograde type A dissection. I think people do that in different ways. We use a combination of our institution of transesophageal echo as well as IVUS. The case I did this morning with the chronic dissection, I use IVUS for all my dissection cases. I know it's not as common in Brazil, but we make sure with intravascular ultrasound that we're through true lumen the whole way with our wires and catheters. And then clearly blood pressure control is critical. For the uncomplicated dissections, we admit to the ICU, we manage blood pressure, we repeat imaging as necessary. Typically, we'll discharge and then follow up in 1 month. For patients that fail blood pressure control or have persistent pain or evidence of malperfusion, we take right to the operating room and treat. If they're doing okay, we watch. If they have high risk criteria, then we will electively treat them with TVAR and typically make a decision whether or not we need to place a spinal drain. If we're doing long length coverage, we will place a spinal drain. If they're not high risk, then we watch these patients under continued surveillance. So clearly this is an evolving paradigm. I think Instead XL has helped us refine what we do. As many of you are aware, there's a renewed interest in clinical trial work for aortic dissection. And in fact, in the US, the NIH has approved funding for something called Improve AD, which is going to randomize over 1,000 patients. I'm fortunate to have been asked to be on the steering committee for that trial, and at the University of Chicago, we will be participating, and we're hopeful we'll get even more information on the management of these patients. As you know from Instead, these patients were randomized anywhere from time 0, basically a presentation with a dissection, almost all the way to a year out. So it's a little bit of a mix of chronicity. 140 total patients, 68 that had best medical management alone, 72 that had TVAR as well. So what's it look like for these patients? So when you add TVAR to best medical management and you look at not the landmark results, but truly the clinical data from year 0 through year 5 of the clinical trial, you see a little over 8% risk reduction for all-cause mortality with TVAR, a little over 12% risk reduction for aortic-specific mortality, and about a 19% risk reduction for disease progression. So part of the reason that I find this fascinating is clearly TVAR is helping in the appropriately selected patients. But even when TVAR is done, there's still a number of patients that you have disease progression. And what we're trying to do with our research, which I'll share with you, is understand that group of patients. How can we predict that quarter of patients that will have a successful endograft placed but still have disease progression. And I'll show you why I think that. So here's one that didn't work as well. And this is a chronic dissection. This is a known chronic dissection, 81-year-old woman. She's a Jehovah's Witness patient, so she does not accept any blood transfusion. So there's no way that anyone would ever consider open surgical repair in an 81-year-old patient that's a Jehovah's Witness. In fact, I think for most chronic dissections, Jehovah's Witness status would really preclude any open surgery. You can see she had very complex anatomy with a large false lumen, very tortuous descending thoracic aorta with a large kink in the mid-descending thoracic aorta. Not very easy to treat from an endovascular standpoint, but really did not have an option for open surgical repair. Did a TEVAR up to the left common carotid, which you can see here. She had a left carotid to left subclavian artery bypass and an embolization of the proximal portion of the left subclavian, a very typical approach. Now, as you can see distally here, it was a difficult decision exactly where to land, and I decided to land above the curve here. Here's your initial CT scan, not very gratifying. You don't see any expansion of the true lumen. You see persistent filling of the false lumen proximally, likely a type 1A endo leak, but not much else I can do, and especially in a patient of this age. Second CT scan, a little bit better, maybe, but still some filling of the false lumen. And once again, really an incompletely expanded true lumen, which to me is one of the biggest markers of failure. If we can't get that true lumen open in the mid-chest, I don't think you're ever going to successfully treat an aortic dissection from an endovascular standpoint. So the question comes up then when you look at this is, how do we decide who to treat, or who do we treat that's just at high risk? And one of the things I always think about is I go back to INSTEAD and look at the first year of INSTEAD. And when you look at the potential complications associated with TEVAR, 8 of those patients that were randomized had complications related to their aorta, or excuse me, 8 mortality in the first year, 7 complications related to aorta or to the intervention with an acute MI. There was one patient who died from a malignancy, so that doesn't really count. But multiple problems that existed here. I think since the time this study was done, we've learned a lot about dissection care, meaning we size devices differently. Many of us know try not to size a device more than 10% oversizing in the acute and subacute phase. We don't balloon. We're very careful with our wire and catheter management. We're very careful with our blood pressure control. We check for retrograde type A when we're done. So we've evolved and we've learned a lot for our intraoperative management, but there still are risks when we do these procedures. So risk of retrograde type A dissection. We know they occur. I actually was just talking to a colleague of mine who said he had 2 in one day, which is pretty discouraging day to say the least. I think all of us see this less and less, but it's still a risk that we worry about. When you look at the different pathologies in the descending thoracic aortic aneurysm, blunt thoracic aortic injury and PAU, and then dissection differentiated between acute or chronic, and look at the risk of a retrograde type A dissection, acute dissection as a disease state has the highest risk of type A dissection. When you look at this relative to thoracic aneurysm disease, 10-fold higher for acute aortic dissection than it is for an aneurysm, and 3 times higher for chronic dissection. So we need to continue to be conscientious. I think many of us are starting to treat earlier on in the very early hyperacute phase. We just need to be very thoughtful with the decision-making in terms of device sizing and our management intraoperatively to prevent a retrograde type A. So in my practice, these are the 3 factors that really impact me the most: a large aortic diameter, a large false lumen, and a large entry tear. I do worry about the refractory pain, and I still am trying to understand exactly the partial thrombosis of the false lumen, and the impact on outcomes. But really, the 3 that I've highlighted here are the ones that concern me the most. So when you look at chronics are really hard for us to treat. And so you see here, this is a patient with a chronic dissection that we've done a very complicated endovascular repair. And I've mentioned to you this before. I don't have all the devices that you have available to you in Brazil. So I have to do things in a slightly different way. So here is a patient that we've done with a fenestrated device after they've had TEVAR because they've had progressive aneurysmal degeneration of their abdominal aorta. So as I mentioned, when you get into this chronic phase, it gets harder and harder to treat. What I've done for this patient is bring parallel grafts for both renal arteries. I have a fenestrated device for the SMA and the celiac. I'm not planning to stent the celiac here, just stent the SMA. Here is the fenestrated device in place with access to this SMA. We had to be very careful as the SMA was dissected. And then here you can see a completion where I have parallel grafts sitting next to the fenestrated device. Here's a reconstructed image of what that looks like. And I think when I think about chronic dissection and persistent false lumen filling and all that's needed to take care of these patients, I think some of the decision is, am I aggressive about trying to treat the false lumen and doing procedures such as a candy plug within the false lumen? Do I want to be aggressive from the true lumen and try to do procedures like a Knickerbocker or some procedure where I expand the true lumen in the chest? Or do I do more true lumen treatment throughout the remainder of the aorta with fenestrated or branched devices? I've shown this patient before as well, 52-year-old man. We had done a TEVAR up above. He had terrible aneurysmal degeneration below this. Here you can see a post-op repair now that we've done this open for the remainder below the TEVAR. And here's you can see what that looks like from a reconstructed image standpoint and intraoperative. So although we are fairly aggressive with endovascular techniques, when we have persistent false lumen filling and need to do more, in certain patients that are younger that we think are higher risk, we'll do with a large open operation. So how do we decide open or endo for an individual patient? Well, I think this is what we're trying to understand a little bit better. So I'll share with you some of the work that we've been doing. So Luka Pochivavsek, who you may not know, but you may have heard me mention before. Luka is one of my colleagues here. He did his general surgery training at the University of Pittsburgh. He came to the University of Chicago for fellowship. He's been on faculty with us for 3 years. He's a brilliant man. He has done some amazing work on understanding computer simulation models for aortic disease, both dissection and aortic aneurysmal disease, and has really done some work with dissection that I think is different than other work that I've seen and fairly unique. So when you look at, here's a picture of some of the people that work at Luka's lab. He's got a really nice big team that are working with him. This is some of the previous work that we've done, looking at mapping for high-risk type B dissections and looking at the dynamic seal at the aortic neck, aortic endograft interface that we've done. And he submitted subsequent grants on to try to understand how we can do better with EVAR for infrarenal devices as well. So what we've done in Luka's lab is turn this around a little bit. So instead of just thinking about this as a timing problem, since he's a mathematician and is smarter than I am with this, he looked at this and said, this is a geometric problem. We all know we intermittently look at an aorta and see that question mark appearance and say, oh, that is going to be very hard to treat from an endovascular perspective. But we're starting to learn it's more than that. So what do I mean? Here are 4 patients. 4 patients of ours, all 4 patients that were treated with TEVAR at a different time point, and I'll explain that for each of these patients. And all 4 of them who required subsequent interventions for false lumen filling or had incomplete exclusion of their false lumen. So I'm going to take you through all 4 of them quickly and then share an example with one of them a little bit more critically. So the red dot is time 0 when they presented with their dissection. And then there are different dots here for purple, an early time point, yellow, a later time point, and then black is the final time point when they've been treated with TEVAR. So if you look here, there's 10 years, 9 years, 7.5 years, and 2.5 years. And these shapes all look a little bit different, but they all had risk factors that made them, what we understand now, high risk for the success of TEVAR. So what do I mean by that? Well, this one's a perfect example. In fact, this patient, you may recognize this anatomy. This is the 81-year-old I showed you earlier with the chronic dissection that I did with TEVAR that I had persistent false lumen filling. So this is what we've done. Luka has looked at something he calls a shape index, and then the curvedness of the aorta. And I'm going to show you in a few slides how some of those calculations are made. This is a group of normal patients, non-dissected patients. This is a group of patients with an aortic dissection who had TEVAR and had the outcome we're looking for, meaning no further interventions and appropriate exclusion of the false lumen. And here's a cohort of patients in pink that had TEVAR and required further interventions. So then when you then look over here and take this same shape index and curvedness for this one patient. So initial presentation, 3 years, 9 years, 10 years, she did not do well. And when we understand why, we believe that if you get treated when you're still in this purple box down here, which will be a little bit different for each patient based on these two factors, if I would have treated her here, she may have had a successful result with TEVAR. Versus up here, she already fell within the window or box where we say this person's not going to have a successful result based on the curvedness of their aorta. Now, interestingly, what we haven't been able to study enough yet is to get the confidence to say we can look at this anatomy and start to predict who is going to be a problem. And Luca has been looking at that, and I'm going to share that with you a little bit as well, because we would love to be able to say, okay, you fit in the purple box, but your maximum diameter right now is maybe only 4.5 centimeters, and not at a time we would typically say somebody needs a repair. Maybe they don't have high risk criteria, best we can tell. But we could project into the future and say, yes, you're only 4.5, but you're starting to get on a trajectory where you're going to fall within that window where you're not going to be successful with TEVAR, and we would treat them more aggressively. So again, here you see all 4 of these patients. Everybody got treated in this pink box outside what we would say is the right geometry to have a successful result with TEVAR. So how has this work been generated? So clearly we're trying to understand the changes in aortic geometry that happen with an aorta with dissection. And here's a typical dissection patient. So what we've been able to do in the lab is take different age patients with different disease states and try to predict and look at aortic shape change. So this occurs in 2 ways. You have shape preserving growth, which I'll show you here in a minute, compared to growth of the aorta with change of shape. So here is, as a patient goes from a pediatric patient to an older patient to an older patient, you have a similar shape of the aorta. And although the aorta has grown, it's preserved. And then here's a dissection with shape change. And then you get to the point of this. So you have persistent growth, but you also have shape change of the aorta. So the way that we've been doing this in the lab is taking CTA images from our patients. And thankfully, we have a nice cohort of dissection patients. Just as an opportunity, as you think about this, we're starting to collaborate with people all over the world. We've set up relationships in the Netherlands. We've set up some relationships in Australia. We're working with some others to collect more and more scans. So if you have an interest, you can reach out to me afterwards and I can connect you with Luca and we can get an appropriate data sharing agreement to be able to start sharing images. Once an image is taken from the CT, we segment with a program called Scan IP and then smooth out the surfaces of the aorta from the segmentation and then create a mesh. So basically you can see how you can go from a typical traditional CT scan to a workable computer model with a mesh surface. We then take that mesh that's made from a computer model and get it into data. So what's that look like? Here are our surface patches and then discrete points to get curvature estimations. And then from those discrete points, we can get an understanding of the total curvature of the aorta. I know this gets a little bit complicated and some of this math and computer simulation, it's hard. Honestly, it's hard for me too. But the bottom line is we're able to look at an aorta, take it from the CT scan, create a mesh model through programming, and then look at discrete parts of the dissection or normal aorta and understand the actual curvature. So then we can take that and look at the fluctuation in curvature. And when you look at this, it lets us create an understanding of what it looks like for the aorta. And then when you look at the different size predictors that have been used before and look at our shape change, it seems to be the most accurate in terms of the statistical models to understand the predictors for shape change that will occur with the aorta. And that's the arrow here. So when we look at this, here I'll show you from this slide, the mean curvedness and total curvature fluctuation, and you take shape and size, there's your pediatric aorta again, larger, 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 and then you start getting to diseased aortas, and you can see the progression right up the curve. Here is once again our distribution of normal aortas, successful TEVAR, and unsuccessful TEVAR based on curvature fluctuation and mean curvedness. So we're starting to understand a little better the trajectory of patients based on this. And here you can see what that looks like. And then we get a better idea that shape within a certain parameter will dictate predict the success of EVAR. So if you're above this line, we have a pretty good understanding that you're not going to do well with TEVAR alone. You may have to do more, whether it's open surgery, whether it's full treatment of the entirety of the aorta. I don't know the answer to that yet, and we don't know from what we're doing in the lab. But what we've learned is for that subset of patients in that box in that corner, TEVAR alone is inadequate. And then this just gives you a better example. Acute, subacute, chronics, but there are differences throughout here. And the other part which we've liked as we've seen this, we've now had access to not just normal aortas here, and not just the TBAD aortas here that we've done with TEVAR with remodeling and without remodeling, but we've had access to clinical trial patients as well, and their true imaging and imaging we've been able to reconstruct. The Gore trials, one was for trauma, one was for dissection. Endospan is a residual, most of them are residual dissections after a type A repair. Medtronic was a de novo type B trial. So we've had access to all of these patients' imagings now and seeing that they fall within the spectrum of what we've seen within our experience here at the University of Chicago. So although this looks fairly similar to what I've shown you before, this is exactly what I was explaining a little bit earlier. So here's a given patient, patient 3. Here was their initial scan. Here's their actual final scan. And what we've been able to do through simulation, recreate the initial scan, and then predict what the same scan would look like at this same time frame. And you can see with the modeling that we're doing, that we're getting relatively good at predicting what the anatomy will look like, which also will allow us to predict the curvedness so we have a better sense if we can be successful with TEVAR. So if we could get to the point where we could take an initial patient like this, model them out over a period of time, and say, yes, this person is going to get into a circumstance where not just that their total aortic diameter exceeds a certain size, but their geometry gives you a certain curvedness where you know they're not going to be successful with TEVAR, we would think about treating that patient differently. And once again, this is just showing you how that simulation is done. So in conclusion, I think, as I've mentioned to you before, type E aortic dissection treatment is still really an evolution. And I think what we're learning in our institution is it's not just timing alone. And we're starting to better understand the geometry of these aortas and potentially predict future geometry for when these need treatment. I still think for many of these patients, elective treatment has a benefit on survival compared to best medical therapy. And chronology alone is not necessarily a bad predictor of treatment success, but you need to understand better what the geometry looks like in these patients to decide who is going to have the most effective treatment. And that's where the research focus is going on in our lab right now. So thank you very much for having me. I'm going to stop sharing screen. I'm happy to answer any questions. I know that this work is a little bit different than typical work that's been done with dissection, but we think it's going to have an impact, and we think it's going to make a difference for the decisions we make for patients in the future and be able to personalize their dissection care.
Congratulations, Ross. It was an excellent presentation.
Thank you, Arno.
It really brought some answers to many of my interrogation points about dissection, which, as just said, is a knowledge in evolution. And your insights are really very, very interesting. I believe that we have to come to the point that we have to treat most of the patients either in the acute or in the subacute phase. We have to really to prove it, and you are in a way of achieving this. So congratulations for your presentation. I've been in this business, as you know, for a long time. Treating dissection now for 24 years. And I treated some patients in the acute phase. In fact, I saw a patient this week, yesterday in my office, that I have operated on her in the acute phase, and subacute maybe in the first 2 weeks. And I implanted an endograft in the starting at the left subclavian and finishing some 10 centimeters above the celiac trunk. And then I implanted another endograft from the renal down to the bifurcation, and open stent dissection graft in the viscerals. And she had a problem because she dissected the ascending aorta 2 years ago. But the part that I have treated is totally okay. So you can manage to treat these aortas. And this is an achievement I think you have to pursue as you are doing. Congratulations.
Thank you so much, Arno. I appreciate that. I appreciate as you know, I always appreciate your kind words, and I always enjoy your just vast experience, and it's fantastic that you continue to share it with us. So thank you.
Bernardo?
Ross, congratulations for this outstanding presentation. I really enjoyed watching. And it's a really complex issue to understand the evolution of dissection and on which cases we need to treat. I think it's a worldwide complex problem. I think sometimes there are some patients that are still had still the label of non-complicated dissections, but they are really complicated patients that remains in the ICU with hypertension, it's difficult to control. And I really think there is a large space to endovascular and surgical treatment in a lot of patients. It's not unusual to find patients with chronic evolution of dissections in big aneurysms, which is a very tough issue to treat. But I really think that the way your group is working, trying to understand the geometry and how is it going to evolve, it's really the way, because you can individualize the anatomy and understand how it's going to be. I have some questions to you. When you receive those patients with chronic dissections, large aneurysms, you have already showed us that in some cases you treat in the true lumen, doing fenestrated and the work, and some cases you treat the false lumen with occlusion. But which are when you choose to treat occluding the false lumen, do a Knickerbocker or a candy plug, or when you go to treating in the true lumen, how do you choose?
Yeah, Bernardo, it's such a good question, and I don't have a good answer for you. I think that some of the decision I make is based on the complexity of dissection, how many other fenestrations are there, the overall risk of the patient, how much of the true lumen is available to work in. I don't have experience with the septal fenestration technique that Gustavo has talked about so much more now to be able to plan some of these fenestrated cases. I think this is another part, Bernardo, that we really need to learn better. And in fact, I'm going tomorrow night to Germany to a dissection course, and one of my presentations is on false lumen treatment. And sure, I can give you all the different options to treat the false lumen. It's not a hard presentation to give, but your question is the good question, and I don't have a good answer to it. How do I decide? And I think some of this, Bernardo, is if it's a younger patient, and I've done TVAR, and I've done TVAR down to the celiac, and I'm, at least in my hands, not having some of the devices that you guys have available, I'm going to have to do funny things or laser fenestrations or something that I just don't think is going to be as effective. A lot of times I'll just do the remainder of that operation open. We have a very good collaboration with our cardiac surgeons, but I struggle to know sometimes the right approach, whether it's a false lumen embolization procedure or more true lumen work. And I don't think we always know why. And we look at the scans and we just say, okay, I think this one's better with true lumen work and this one's better with false lumen work. And I don't have a good sort of algorithm in my mind yet when I should do one or the other. I think your question's a really good question.
It's the $1 million question.
How about yourself, Bernardo? I mean, I know you have a fair bit of experience with this. I mean, how do you, with some of you guys have some branched and fenestrated devices that I don't have? I mean, do you prefer to stay in the true lumen, or are you aggressive with false lumen ablation procedures? What do you typically do in your practice?
When we got I think it's difficult to generalize. I think it's really a case-by-case decision. It's difficult to have an algorithm. And the cases I have submitted to false lumen occlusion, they got the false lumen restricted to the thoracic aorta, and there was a good place to park. I use plugs. We don't have any candy plug device here like in Europe. I don't know if you have it in US, but we use it here, the Unplatzer plug, large Unplatzer plug, and it sealed. It was a very interesting case. It was a Marfan guy that he got a thoracic dissection. He got a expansion, a rapid expansion. The cardiac guys didn't want to operate him because he already have some previous surgical work, and we embolized the false lumen, and he's okay, and the false lumen is smaller now. The dilatation is smaller now. And that's goes to my next question. Do you think is there space for endovascular work with people with genetic aortic disease like the Marfans, or on special issues, people with very high risk for open surgery?
Yeah, so I think that's Bernardo, you're asking all the hard questions tonight, which is good. I like it because you clearly have been thinking about dissection like we've been thinking about dissection. So, it's interesting, Bernardo. We have changed our approach with this a little bit. We've been fairly aggressive now about patients that present who are under 60 years old with a type B dissection, doing fairly aggressive genetic testing. Not in everybody, but we've been trying to do it more and more. The younger patients with the collagen vascular disorder that can tolerate open surgery, we tend to do that more with an open surgical approach. If they're older for whatever reason, which I realize is not the typical, genetic disorder patient, but if they're older or if they're too high risk, meaning they can't tolerate being on any sort of extra anatomic bypass while we're doing the procedure, whether it's LAFA bypass, FEM, whatever, we will do those with an aggressive endovascular approach. I mean, I have the patient that I showed you that I did the renals on, who likely has a collagen vascular disorder, but he's a morbidly obese man. He's about 130 kilos. He's not going to do well with an open thoracoabdominal replacement. So, we vary that based on the patient's risk, but in general, if they have a documented genetic disorder and they're younger and can tolerate an open surgical approach, we tend to do those patients with open surgery.
Okay. And it's very interesting how the branch device fits inside the true lumen, and the true lumen expands. It's really interesting. When I started doing branch endografting for dissection, I was really concerned about compression, but it really looks that after decompression, the true lumen could expand, and everything suits better.
Agreed. I think, Mark Farber, who I know you all know very well also, Mark has a very good description of this. And the way he thinks about this is, as long as you depressurize the false lumen with whatever technique you use, that you don't have pressure in the false lumen anymore, the true lumen is going to expand. So if you do it a complete true lumen treatment and treat down into the iliacs, and you've covered all the fenestrations and you depressurize the false lumen, he really feels like that will be effective treatment because the true lumen will expand.
Yes. We have some questions from the audience.
I see that. At least I don't know if I'm seeing the same ones you're seeing, but Dr. Billman had asked about how the length of coverage that I use. Are you seeing the same questions I am, Bernardo?
Yes.
Yeah. There was three from Dr. Billman that I saw. So the first one is, typically, I usually finish about 2/3 of the way in the chest after I've covered the proximal entry tear. Part of the reason I do that is I always get a little bit concerned with the risk of paraplegia going all the way down to the celiac if I don't need to. If it's a malperfusion or rupture case and I have no choice, I will. And if it's a malperfusion case and I've gone down to the celiac, I'll put a bare metal petticoat stent in after that to really open up the true lumen. I mentioned earlier, I don't have experience with endovascular septotomy. One of my prior trainees has spent some time with Gustavo and has explained it to me. It sounds like a very reasonable sort of management plan. I actually use a lot of thermal procedures with wires to do type 2 endoleaks, which I think I've shared with you all before, but I haven't done it for a septotomy. The next question was about stabilize. I've not been very aggressive with stabilize as well. When we've used the bare metal stent, it's just in the setting of acute malperfusion when we haven't corrected it with TVAR alone. And I really don't know, there's a lot of discussion about stabilize. There's not a huge amount of data yet. I know Germano Melisano has really been the one who's promoted that. There still isn't a reasonable number of those patients, from what I understand, about 1/3 to 40% of patients that still have an issue with the abdominal aorta, even after the stabilized stent has been put in there. So I'm still not convinced it's the perfect approach, but it does accomplish a little bit what you and I talked about, Bernardo, is hopefully obliterate the false lumen in the chest, at least.
Abraço aí, Vitor, que está em Israel. Grande abraço, Vitor, um amigo nosso. Obrigado pelas perguntas. Se alguém mais quiser fazer alguma pergunta, por favor, pode colocar aqui no chat. It's really a very interesting topic, but Dr. Arno, I think he got an opinion about stabilize. Actually, we have the nano and the luminal did some years ago a device that we used, and Dr. Arno got late results of this device. Dr. Arno, do you want to talk about that?
Interesting, because we started to use open frames, we call that stent, in the year 2000. We didn't get a patent on that because we didn't believe, I think it was an important thing. And I had this patient that was operated in the year 2000. In fact, was a girl. She was 17 years old those days. And we implanted, she had a lot of iatrogenic problems that I speak from a long time. But I implanted an open frame, and she's still alive today and working and doing well. She's 40 now. So we have used some specific to avoid as much as possible paraplegia, which I think it's a major disaster. And I think it has some value. But we don't have a series in there. So just anecdotal case. Okay.
Excellent. Well, thank you. Thank you so much for having me. It's really an honor to join you this evening, and I appreciate, as I mentioned earlier, really appreciate the invitation. I've always appreciated how kind you are to me, and I have a tremendous amount of respect for the work, Arno, that you and your group does, and the people that you've trained, and it's a great honor to be here. So thank you.
Our privilege. Thank you very much. Bernardo, your final thoughts?
Thank you, Ross. Thank you for being with us. It was a great pleasure to see you again and watch your presentation, outstanding presentation and work. You are really a friend of Brazilian surgeons. Thank you very much. And I also like to thank everybody that was here at the Clube da Artéria. Muito obrigado, amigos. Foi um grande prazer estarmos juntos. Até o próximo evento. Um grande abraço a todos. Bye, bye, Ross.
Bye. Boa noite.
Boa noite.